I have the privilege now to introduce someone that I have never had the privilege to speak with. However, I have always wanted to. It's Dr. John Goodman, who is a healthcare policy analyst. I've read his work. I've admired a lot of the things he said, and I support a lot of the concepts that he's brought forward. He's a senior fellow at the Independent Institute, where perhaps you've read his work. He's the president of the Goodman Institute and the author of the new acclaimed book, A Better Choice, Healthcare Solutions for America, and the award-winning Priceless, Curing the Healthcare Crisis. The Wall Street Journal and the National Journal have called him the father of health savings accounts. And without further ado, Dr. John Goodman to speak about how to replace Obamacare. Thank you, Dr. Goodman.
Wow. After an introduction like that, makes you think you should run for office or something. I'm John Goodman. I approve that message. Actually, I thought our office was being a little generous when we suggested some of those remarks you just heard, but I enjoyed every word of it. On a different occasion, I would stand up here and tell you more jokes, but today I want to get real quickly into some serious stuff because I want to get your reaction to it. You know, it's been 5 years since Obamacare passed, and in all that 5 years, there's not been one Republican member of Congress who's been willing to stand up and say, here is an alternative to Obamacare. Here is what the Republicans will do. Here's how the health care system would look if we were in charge, and present a plan that at least is in some way credible to cause us to believe that costs would go down, quality go up, and access would be better. The possible exception would be Senator Cassidy. Did he speak to you the other day? He doesn't even have one co-sponsor, though, on his Senate bill. So what is it that's causing our side, and by our side I mean conservative, libertarian, right of center, why can't the right of center side come together and agree on what would be the alternative to Obamacare? And I think there are three big problems, and the first of those is that people on our side do not understand what the problem is that's keeping us from having a free market healthcare system and what we'd have to do to get there. You know, I brought this cell phone with me because you never know, in the middle of a speech you might have an urgent call, right? That's not serious. I brought this cell phone because I want to make a point that in Dallas, Texas, if something goes wrong with my phone, there are a dozen places that I can stop into without an appointment and get pretty prompt service, and it'll be fairly inexpensive. It will be high quality. There are services in Dallas that will send someone to my condo to repair my iPhone in my condo. There's a nationwide chain. It's called iHospital. The people who work for it are called eye doctors. And yet if something happens to my body, the average wait in the United States for a patient to see a new doctor is 3 weeks. In Boston, where we're told they've had universal coverage for some time now, the average wait is 2 months. And 1 out of every 5 individuals that walks into a hospital emergency room leaves without ever seeing a doctor because they get tired of waiting. So my question to you is, why is the market so kind to my phone and so mean to me? And I think the answer is that this phone is produced and repaired in a real market with real prices where entrepreneurs know they can make millions of dollars by meeting our needs. Whereas over in healthcare, we have so completely suppressed the market year after year, decade after decade, that no one ever sees a real price for anything. No patient, no doctor, no employer, no employee. Now, how did all that happen? Well, the principal way it happened at the federal level is through the tax system. And because of the tax system, we're all encouraged to get insurance through an employer, and that's group insurance. And because it's group insurance, when we leave the employer, we lose the insurance. And then we've got the whole problem of pre-existing conditions. And then the tax law encourages us to get third-party insurance rather than self-insurance through a savings account. Yes, we do have health savings accounts now. Yes, there are 30 million people who have them. But by and large, the law is still encouraging us to give more of our dollars to the insurance companies than to put them in a savings account. And finally, the tax law is encouraging us, because it's open-ended, to overinsure. So it encourages us to have more insurance than we would have under a more rational system. Now, at the end of the day, we have third-party payers paying every medical bill. And when third-party payers pay every medical bill, you don't have any real prices. And that's where we are. Now, if you want to back out of that, we have to undo the perverse incentives that government has created. And those are perverse incentives. And when we act on those perverse incentives, we, by we I mean the patient, the doctor, all of us, we do things to make costs higher, quality lower, and access more difficult than otherwise would have been the case. And we're not going to get out of that unless we correct those perverse incentives, and that means changing the way that we subsidize health care through the tax system for all Americans. Now, Obamacare is really only subsidizing fewer than 20 million people. There are another 150 million people whose incentives are just as bad or worse because of Obamacare than they were before. 150 million people getting insurance through an employer can all lower their taxes by buying more third-party health insurance. That's what has to be changed. And that's what the Republicans are very reluctant to do. They're very reluctant to stand up and say, okay, we're going to change this system. And Senator Cassidy, again, is the exception. Now, for Obamacare in particular, let me just run through three big problems, and then let me go to the solutions. The three biggest problems with Obamacare are, number one, that it puts us on a path that is impossible. Obamacare is forcing you, me, all of us to buy a package of benefits. It's telling us what has to be in that package, and the cost of that package of benefits is going to go faster than our income. This isn't the problem that Obama created. For the last 40 years, real health care spending per capita has been growing at twice the rate of growth of our income. And this isn't a unique American problem. It's true all over the world, and we're not the worst. We're sort of in the middle of the pack on that growth path. But you don't have to be an accountant. You don't need a pocket calculator to know if you're buying something and its cost is growing faster than your income, it's going to crowd out other consumption. And if we stay on the path we're on, by the time today's college students reach the retirement age, they'll have nothing but health care. They'll have nothing to eat, nothing to wear, nowhere to live. They'll have only health care. Clearly, that can't happen. Now, again, Obamacare didn't create the problem, but it locks us onto a path. It makes it very, very difficult to make sensible changes in the insurance plan that you have to lower costs and increase quality. For example, the law says that healthy women are entitled to a free mammogram. But if a woman has symptoms and really needs the mammogram, then she's paying for it out of pocket. Now, in a rational world, we'd flip that around. You know, mammograms for healthy women are controversial. I don't need to tell you all that. So let people make their own decisions with their own money. But if the symptoms indicate we really have a problem, that's when we want it to be free. That's when we want the woman to really have the mammogram. But the Obamacare law doesn't allow us to do that. Meanwhile, and this has been not reported anywhere outside things you've seen me write, the federal government has limited its exposure to all this in three very significant ways. As part of the Obamacare Act, Medicare going forward forever is going to grow no faster than national income. As part of the Obamacare Act, Medicaid hospital spending is going to grow no faster than national income. And beyond 2018, the federal subsidies in the exchange are also tied to national income. So we have health care going like this, government's share going like this. That means more and more cost shifting to the private sector. That is an impossible burden. That cannot go on forever. Now, the second big problem with Obamacare is a bizarre system of subsidies that are really hard to understand. In most states, at 138% of poverty, a family of four can go into Medicaid and get free health care. And it costs about $8,000. So let's call that an $8,000 gift. If this family makes $1 more, they can't be in Medicaid anymore, and they have to be in the exchange. And at that level, they're like the employees at this hotel over here, the maids, the busboys, the waiters, the waitresses, people making $15, $20 an hour. They go into the exchange, they can get insurance that, let's say, for a family, costs about $12,000, and they have to pay about $900 out of their own pockets. Let's call that an $11,000 gift. So we have $8,000 gift, we have $8,000 gift, $11,000 gift, and for the employees over there, if they don't spend an equivalent amount of money, if they in the hotel don't spend an equivalent amount of money on health care, then they can be subject to a $2,000 fine. So $8,000 gift, $11,000 gift, $2,000 fine, that's bizarre. And if we don't change it, we'll change the way American industry employs people, we'll change the number of hours they work, we'll change the size that businesses will grow to. It will have severe economic effects. And the third thing that Obamacare, the third problem, and this is something that no one else talks about other than me and my colleagues, has to do with perverse incentives for the insurers. You don't have to be in the business to know that if you're selling insurance and you have to sell at the same premium to everyone regardless of health condition, that you're probably going to make a profit on healthy people and losses on sick people, right? And we know there are all these complicated risk adjustment mechanisms in Obamacare that last about 3 years. I haven't been able to sort through it all, but I'm just watching the behavior of the insurers. And it's very clear what they think. They want healthy people and they don't want sick people. And that's why you get the very narrow networks. We're getting a race to the bottom. In Dallas, Texas, Blue Cross in the exchange is paying doctors 10% less than Medicaid pays doctors. And so it throws a price out there. It takes all the doctors who will accept that price. That leaves out most of the best doctors and the best facilities. But they don't care because this is a race to the bottom. And the insurers have concluded that if they can get the premium, if they get the cost down, they get the premium down, the healthy people buy on price. Healthy people don't look at networks. The only people who look at networks are sick. And so if I'm an insurer and you want to know about my network, I don't need to know anything else about you. I already know I probably don't want you in my plan. That's probably the single worst thing that's happening in Obamacare, because the bad incentives don't stop at the point of enrollment. After you've enrolled in the plan, the perverse incentives are still there. They want to overprovide to the healthy to keep the ones they have and attract more of them. And they'll tend to underprovide to the sick because they want to get rid of the ones they have, and they certainly don't want to attract more of them. All right, what can we do about all of this? What would a Republican, what would a conservative health care reform look like that would be different from Obamacare? Well, let me just point out a way of thinking among Republicans that I think holds us back and blinds us to the opportunities. Imagine that over here we have health care before there was Obamacare, then now we have Obamacare, but up here's where we all want to be. And so I know lots of people in Washington who think we've got to go here before we go there. We've got to repeal Obamacare in order to do this. And the likelihood of that happening is almost zero. You know, even if you poll Republicans and they didn't have to, in private, if you privately poll Republicans in Congress, there are not more than 1 in 4 that think we'll ever repeal Obamacare. But even if we could, remember, here's before Obamacare, here's where we want to be. Even if we could repeal it, is this the best way to go? Why not do this? That's a lot easier to do. And so that's what I'm working with Pete Sessions and some of the leadership in the Congress right now with a bold, conservative alternative to Obamacare. And we're not trying to do this, we're trying to do that. And let me just point out one thing that's very important about that is a hang-up for conservatives. If you think about Obamacare as having 2 parts, there's the spending regulatory part and there's the income part. The income finances all of this. It's over here on the spending side and the regulatory side, that's where all the bad stuff is. That's what we want to repeal and replace. But over here on the revenue side, that's a stream of revenue that's available not just for Obamacare, it would be available for us if we wanted a better health care reform. Now, where's all that money coming from? Well, more than 2/3 of it comes from special interests who agreed to be taxed or agreed to have lower benefits in order to get health reform passed. And who are all those folks? They're the drug industry, the health insurance industry, the business roundtable companies, the labor unions. All those folks agreed to be taxed so that we could have Obamacare. One of those companies told me that Obamacare is costing them $1 billion a year. And I said, well, are you asking for the $1 billion back? And they said, no, we're not. So we have, over the next 10 years, $2 trillion of revenues, most of it coming from special interests. special interests who, by the way, sold all of you out, including the American Medical Association. They're not asking for the money back. And so what I'm saying is, let's don't give it back. And this includes ARP. ARP sold out the seniors. You know, more than a third of the funding for Obamacare comes from cuts in Medicare, which ARP agreed to because it makes more money selling insurance than it does on member dues. The AMA agreed to all this because they make more money on the billing codes than they make on dues from people like you. So I say these folks don't deserve their money back. They're not asking for the money back. We have $2 trillion on the table. What is a conservative, a libertarian thing to do with $2 trillion? I would say is to have a tax cut. But it's got to be a tax cut paid, tied to health care. Now, the tax cut that we are proposing is a universal health tax credit, which looks like the child tax credit. Let's treat everybody the same. Instead of these wildly arbitrary ways of subsidizing health care, let's give everybody a sum of money, a certain number of dollars, and that can be applied to health care, just like the $1,000 tax credit. Everybody gets it if you have private health insurance. I think right now we're talking about $2,500 for an adult and $8,000 for a family of 4. The reason we chose those numbers is because that's what it costs to put people in Medicaid. So if you just took your health tax credit and you went out into the market with it, you'd be able to buy Medicaid-like insurance. So there's a floor under what you could afford. You put extra dollars in from you or your employer after tax dollars, you could have more choices and better insurance. But there is a uniform tax credit available to everybody, and then government gets out of the way. We get rid of all the mandates, so there's no individual mandate, there's no employer mandate, individual choice, and the market determines the results. We have got to first undo all the perverse incentives that are created by the current system in order to get to a better system. A Republican alternative to Obamacare has to clearly reflect traditional Republican values. And let me just point out a few of those values. One is choice. You choose a plan that meets your needs and your family's needs and not the government's needs. So no employer mandate, no individual mandate, individual choice in the market determine what kind of insurance you get to have. Number 2 is fairness. We treat everybody alike. We don't have the union over here getting one deal and these people over here getting another. Everybody gets the same tax benefit for health care, and then they make choices on what to do with it. Number 3, we have a patient power. We have a Roth health savings account that will wrap around any third-party plan. None of these restrictions are in the current HSA law. A completely flexible account that can fit together with any third-party payment plan. Let the market determine how much self-insurance, how much third-party insurance, not the government. Portability. All the provisions of federal law which tell employers that they cannot provide for their employees insurance which the employee owns and can take from job to job and in and out of the marketplace, all those are gone. So we don't tell the employer he has to buy portable insurance for the employees, but we take away all the barriers to it. There are lots and lots of employers right now that would like to go to, you probably read about it, they'd like to go to a defined contribution system where they put up a certain number of dollars for their employees, but employees can choose what kind of insurance they want. Right now, Obama not only is trying to stop it, but is imposing huge fines on employers who do anything like that. We need real protection for people with chronic illnesses, which means we need real insurance. And let me just take a moment to describe how that works, because this is the most important reform of all. It didn't get in the Cassidy bill. And I told Senator Cassidy, of all the things that are in his bill, this was the most important, but none of his colleagues could understand it. I told you a minute ago we've got a race to the bottom, that these plans are trying to track the healthy and avoid the sick. And after enrollment, they're over-provided to the healthy and under-provided to the sick. If that continues, we'll have really perverse outcomes. Contrast that with what's happening in the Medicare Advantage program. About 1 out of every 3 seniors is in a private health insurance plan under Medicare, right? We call it Medicare Advantage. That's community rated. It's guaranteed issue. So why aren't we having those problems in Medicare Advantage? Because we've got a very good risk adjustment program there. Probably the most sophisticated risk adjustment formula in the whole world. It has 72 variables. It's not all that great, but it's better than anything else, and it's working pretty well. And what it means is that when the senior goes into a private plan, Medicare looks at the health condition of the senior and tops up his premium so that the premium that is received by the plan is actuarially fair. And this means that to the Medicare Advantage plans, the sick are just as attractive to them as the healthy. And you have plans that specialize in taking care of seniors with lots and lots of problems. These are the special needs plans. And they get $60,000 or more for a senior. Whereas for a healthy senior entering one of these plans, the payment might be $5,000 or $6,000. So Medicare does a pretty good job of making that kind of risk adjustment. Now, what should we do with the Obamacare exchanges? I want to deregulate them, denationalize them, and create free markets out of them. But how do we get the Medicare Advantage system to work for our free market system? Well, I don't want Medicare telling plans what they have to do. So our proposal is to start with the Medicare Advantage risk adjustment program. So if someone, say, moves from my plan to this gentleman's plan, that enrollee, if he goes from silver to silver, pays the same premium that all other silver enrollees pay. But then, if that's a patient with cancer or serious health problems, I have to make an additional payment to that plan so that they receive an actuarially fair premium. And we start with the Medicare Advantage formula. In fact, we don't need to reinvent the wheel here. We can send the health information to Washington. They can come back with a risk score. But that's where we start. And then the plans are free to improve upon that. And we could have 6-month look-backs or 12-month look-backs, or they could do all kinds of things. And that's what I call free market risk adjustment. As long as the insurance companies are free to negotiate with each other, we'll get to a better risk adjustment than even Medicare Advantage has. So I don't think, as a practical matter, that we're going to get away from guaranteed issue in community rating. Now, I think that the American public does not want people to be discriminated against because of health condition. Remember, the whole problem is created by bad federal laws, which put everybody into group plans, and you lose your insurance when you leave the group plan. But the voting public doesn't understand all of that, and so that's where we are. You play, with the cards that are dealt you. But we can take that given and turn the market still into a fairly a good free market for health insurance with that mechanism that I just described. It's really hard to describe to voters, and I don't even know that we need to describe it to voters. I think the central message here is that what Obama promised them was bait and switch. Obama told all these people that the insurance companies weren't going to mistreat them anymore. And sure enough, the insurance companies can't exclude them because of a health condition. What he didn't say is, by the way, they're going to get narrow networks. You're not if you have cancer, you won't be able to see the best cancer doctors. If you have heart problems, you won't be able to go to the best heart hospital. That was the bait and switch. With the kind of free market risk adjustment I'm talking about, plans would specialize. You'd have plans specializing in cancer care, heart care, and that's what we want. The other day I learned that Cancer Treatment Centers of America came that close to doing a deal with Kaiser, where they would take all their cancer patients. That's the sort of thing that I imagine would happen in a free market for health insurance. Why would one plan think it could handle all needs equally well? Why not let plans specialize? We need a market for sick people, and that's what we would get. Finally, we need a real safety net. Places like Parkland Hospital in Dallas, Cook County in Chicago, Grady in Atlanta, they're in trouble because Obamacare is taking away their DISPRO money. And the theory was, well, if we have more people insured, you don't need all this uncompensated care money because you'll have lots more patients with insurance. What they forgot was that in Dallas, Texas, if I have insurance, I'm not going to go down to the Parkland Hospital emergency room and wait 5 hours. for my care, I'll go over to Presbyterian or Medical Cities Dallas. So Parkland isn't seeing the people with health insurance. They're going somewhere else. So safety net institutions are in real trouble. And so here's what we're proposing. We offer everyone the tax credit, just like the child tax credit. Some people are going to turn us down because that's just the way the world is. And when they turn us down, we don't just put the money back in the Treasury's bank account. We send some portion of it to local safety net institutions. So when the uninsured go into the hospital, they'll be expected to pay their own bill. But if they can't, we have backstop money so that the care is available. So under this proposal, money follows people. If everybody in Dallas gets health insurance, which is what we hope they will do, private health insurance, then the subsidy goes to private health insurance. But if everybody in Dallas decides to be uninsured, then there's money available for safety net institutions. That's as close to universal care as we're ever going to get. I notice up in Canada, there are 2 provinces where people actually have to pay money to be part of the Canadian Medicare system, and they have 5% uninsured in both of those provinces. So whenever people have to pay some of their own money, they'll turn you down, and we need some provision. We need some plan on how we're going to do it, so that we really do have universal care. Okay, I want to stop now and open up for you. I've already told you there's a bill. I've outlined where we're going with it. I've told you I think it's consistent with traditional Republican, conservative, libertarian values, and is definitely an alternative to Obamacare. And I'd like to see our folks out there talking in a bold way about how the system could be different, instead of this nibbling around the edges. We're going to repeal the salon tax one day, the device tax the next, and make this little change over here. That's what the Republicans are doing, and I wrote a critique of them the other day. Paul Ryan called me up and he said, well, Goodman, we're going to handle this problem 2 years from now. And I said, well, Paul, if you guys don't have the courage to do it today, I don't believe you're going to do it 2 years from now. So you believe me? Thank you. All right, with that, let's open it up for questions. Or comments, or yes, ma'am.
Hi, I'm Dr. George. I just have a question about the third-party payer aspect of this. That doesn't change. So you can have more people carrying insurance, but when they have to use it, they get denied still for not medically necessary, experimental. How does that change?
I'm not sure I caught all of that. I want to see third-party payment, and I want to see third-party insurance and self-insurance with a health savings account on a level playing field. Right now, they're not on a level playing field. So I want to see a completely level playing field. Then the market will determine how much of one we have and how much of another. I mean, I would think insurance would emerge so that individuals will be paying from the health savings account virtually all primary care, virtually all diagnostic tests. And third parties would intervene only for the really expensive things. But even on the really expensive things, there's a role for the health savings account. And let me just give you one example of something that happened in California. I thought this was really, really interesting. How many times have we been told that in order to deal with hospitals, you have to have a big, big employer, a big insurance company or government, that the patients on their own can't deal with hospitals, right? This is what WellPoint did with the California employees. This is the CalPERS plan. There are thousands and thousands of employees of the state of California and their dependents and retirees. And the state and WellPoint said to all of them, look, we've looked at knee and hip surgery throughout California. We've identified 46 hospitals. These hospitals routinely do these procedures for $30,000 or less. So if you guys go to these 46 hospitals, you have the normal deal, and that's all you're going to pay. But you can go out of network if you like. But all we're going to pay if you go out of network is $30,000. Now, two-thirds of the people did go out of network. But within 1 year, the out-of-network cost fell by a third. And within 2 years, the average out-of-network cost of a hip or knee replacement in California went below $30,000. And this is without WellPoint not writing a single letter to a hospital, not making one phone call, not negotiating a single price, just empowering the patients, empowering them in the sense of saying, you have $30,000 to spend, and go spend it the way you want to. And the minute that the doctors and the administrators learn that, they immediately change what they are doing. That's the power of patient power.
Is it going to be administered by anybody, or you get to spend your health savings account the way you see fit? Or is it administered by an insurance company? How does it work?
Well, the market has to determine.
But my question is, I have a health savings account.
Yeah.
I pull my money out, I go to whomever I want,
yeah.
Or am I carrying a Blue Cross or some other card to administer it for me?
That's what I'm saying. It depends on the third-party insurer that you select.
Well, you have to select one then.
Well, if you don't have some kind of creditable third-party insurance under our bill, you don't get to have a health savings account. And we're not telling you what it has to be. It's like for years and years and years, the federal government said to employers, you know, if you buy insurance for your employers, you don't have to pay taxes on it. We're approaching it the same way. It has to be. It can't be a sham. But as long as it's not a sham, sky's the limit. And that gives you and Blue Cross the freedom to combine your health savings account with their coverage in any way you want to do it. And so you can do things like what WellPoint did. You can do other things. We want you in the marketplace to make these decisions, not government.
But the problem is,
we got to
can I ask you one last question or statement? Yeah. The problem is the insurance companies work at odds against what the doctor and patient want. That doesn't change in your system, and that needs to.
Yes, but I can't. Here's what I can't change. I can't change self-interest. I can't change the self-interest of the doctor or the patient or the insurance company. But one thing we can do is we can get rid of perverse incentives, and we can stop the federal government from being the subsidizer of perverse behavior. Yeah.
Thank you very much for coming to speak with us. Did I understand you to say that it would be a good thing if the Cancer Care Center took care of all of Kaiser's cancer patients?
No.
Good. Thank you.
Because I don't get in that kind of judgment. But I think it's a good thing that they were negotiating, and I think it's a good thing that plans think about specializing in certain kinds of care, and then competing for those kinds of patients. Cancer Treatment Centers of America is on TV all the time. You all see the advertisements, I assume. You ever wonder why they're on TV? You know, you don't see Humana on TV saying, send us cancer patients. You don't see United Health saying, if you got cancer, come to us. Cancer Treatment Center is on TV because the marginal cost of their care is paid out of the pocket by the patient. Okay? And so I want to extend that idea and create a real market for sick people. And I think we would find that centers and plans would specialize in care for certain kinds of diseases. They'd get better at it than anybody else, and we get a real market for sick people.
My thought is that.
Do you believe your plan will actually get hospitals to compete based on price? Because now they compete based on commercials and things, but they've never competed based on price. And if the patients have a share in that, and would that help the hospitals to compete based on price, and then you could have a more conventional insurance scheme rather than something that regulates everybody?
All right, hospitals do not compete on price whenever third-party payers are paying the bill. Okay.
Correct.
Many of them will compete on price when the patient is paying the bill. So Canadian patients have figured out how to come down here to the United States, going through an agency, and they negotiate a price up front, a package price, and American hospitals will do their knee replacement or their hip replacement for half of what we Americans are paying. So the Canadians are smarter than we are, or turn it around. The hospitals know that if you have a paying patient that you're going to lose if you don't negotiate, there are all kinds of hospitals willing to negotiate. The market for medical tourism is really growing, and employers are now getting into this market. And if it gets large enough, then you'll find, well, I don't have to get on a plane to get, the hospital to tell me.
Right, but in Canada, you do have to get on a plane, though, because it's illegal to purchase medical services that would otherwise be paid for by the government. It's not legal. That's why they come to this country. because it's not legal for them to purchase it.
Now, what I mean is that Americans, you and I,
right,
Americans,
we still can. We still have that option.
We can do what the Canadians do. In other words, if you want to go through the same service that a Canadian uses to get a price in advance, you can do that. And services are developing. That medical tourism market is growing, and it's going to put tremendous pressure on local hospitals to start pricing their product.
Great, thank you.
Yes,
Dr. Zwelling, you have a question for Dr. Goodman?
I have a question and a statement. So first of all, John, thank you. You probably heard a lot of the same things today that you heard yesterday from me. So John has been working with Pete Sessions, and I've been working with Pete Sessions, but so have doctors from all over the country. Chris Held has been working with him. So this is a doctor-based plan, some ideas about choice. So I'd like you to talk to the choice thing. This audience wants to hear about choice. Everything needs to be centered around patients' opportunity to make personal choices, to pay for them, for those prices to be posted, for informed choice. That said, I'm hoping that you're writing down all your comments, because we are going to go back to Washington, and I hope you'll join me and join other physicians. We're going back there where our voice can be heard. These plans should not be made behind closed doors where we don't have a voice. So that's why I'm here. That's why John's here, because I want your voice involved in the process. Because in the end, we're going to have a system that's built by doctors and patients that works.
Did you want to respond to that?
When I started out with health savings account idea in the early 1990s, I went to Washington. There were only a handful of congressmen that even wanted to talk to me. They introduced the bill. I think they had 6 sponsors. I think Rick Santorum was one of them, by the way. But all the insurance companies were against us. The trade association, HIA then, AHIP now, they were all against it. The AMA was against it. The business groups were against it. I don't mean that they went out and lobbied against it, but they just weren't for it. And their belief was that patients can't make good decisions, that the patients can't bargain with hospitals and large institutions. And so we go 10 years, and all of a sudden their view of the world begins to change. I mean, they tried everything else. Nothing else was working. And now another 10 years, and I'm seeing in the insurance world a huge appreciation of the power of patients spending their own money. So I gave the example of WellPoint telling its employees, you have $30,000 to spend, go into the market and spend it, and how the supply side responds. But it's not just limited to that. We're all MRI scans, tests, they're experimenting with all kinds of services like this, where patients know they have a sum of money, they can go wherever they want to go, they price shop, they comparison shop, they look at quality indicators. I think we're moving into the era of patient power. And big companies like WellPoint have figured out that patient power is more powerful than they are. But I want the federal law to be consistent with this. And I want the federal law to get rid of these perverse incentives and provide a level playing field under which all this can develop.
Thank you. Dr. Arvind Cavalli from Bucks County, Pennsylvania, an endocrinologist.
Hi, John. Thanks. Read your book. Question for you and a suggestion. I believe in grassroots education and about everybody being educated, including our, we are a physician, mostly physician group here, talking about nurses and patients and even politicians. So what plan do you have for us, since this is a nuclear group and we buy into your idea of your new proposal? What plan do you have to disseminate this message through us so we can educate most of our colleagues about this idea? Because I believe that most of our colleagues in the medical profession do not understand the health savings HSA/high deductible plan idea.
I agree with you. They don't understand it. My goal, my educational goal, is to have us all understand that there is a free market alternative to government-run healthcare system. And it's not essential that everybody understand everything about it, but it is essential that we have a vision and that everybody is clear that there's an alternative vision to the Obamacare vision. And over on the left, their vision of health care is you're sick, you go get care, and the government pays for it. It's very simple. That's how the left thinks about health care. And if the exchanges go into a death spiral, they'll be taken over by the government, and that will just be one more Medicaid program. And we'll have, at least for that group of people, socialized medicine. But
physicians don't buy into it. That's my feeling.
Okay, that's why I'm here. You all need to learn more than what voters learn, and so get the plan from us. Marty will help you do it. You want to receive stuff directly from me? I've got to leave here in 10 minutes, but give me a business card and I'll email you stuff. But you guys need to get informed about tax issues. I've been talking about tax issues today. I watch your videos, nothing about taxes on the video, but we need to understand that down below, it's the tax system that's creating so many of the problems you are having.
Exactly. Thank you.
Right. Yeah.
Well, thank you, Dr. Goodman. In closing, what are your thoughts as far as what not only physicians can do, but any patient citizens can do to be active also, because it's going to take a world of people to make a change?
Here is something we all can do, because I've been talking to a lot of Republicans on Capitol Hill, and they think they can go home and get reelected and not have any alternative. All they have to do is vote to repeal Obamacare when they know it's not going to go anywhere. It's not going to get through the Senate. Even if it did, the president would veto it. So those are free votes. I mean, they never have to confront what would really happen if they abolished Obamacare, which would be a big mess, by the way. They all were, I won't say all, many of them, including the leadership, were relieved that that Supreme Court decision went against us and went for Obamacare. Because if it had gone our way, then they would have had a big mess on their hands. They don't want to deal with this problem. They're around the edges. They want to repeal the device tax, repeal the tan-saloning tax, do these little things that don't really amount to anything. They don't want to take on Obamacare. So what we can do is when they come home and ask for our vote, say, we're not going to vote for you if you don't tell us how you would replace Obamacare. What's your vision? What would health care look like if you were in charge? And we need to put pressure on them. Okay?
That's definitely important. If somebody wants more information about yourself, the Independent Institute, the Goodman Institute, or your books, what would be a good point of contact?
Okay, you've all got a flyer. If you Google Goodman Institute for Public Policy Research, you're going to see me. And you can sign up for things. I'll send out regularly health information. I blog at Forbes 2 or 3 times a week. I'm at Town Hall every weekend. So I'm putting up a lot of stuff that you might be interested in.
Well, thank you again for all your good work and spending your time and resources being here with us. Thank you.